Child and Adolescent Mental Health Nursing. Unit 1, Module 5, Adverse Childhood Experiences, also known as ACEs, Risk, Dose Response, and Clinical Implications. In the previous modules, we explored how brain development, environment, and stress shape childhood outcomes. Now we introduce a framework that helps us measure risk, adverse childhood experiences, or ACEs. The original Adverse Childhood Experiences ACE study, conducted by the Centers for Disease Control and Prevention and Kaiser Permanente, identified 10 categories of adversity occurring before the age of 18. These categories are grouped into 3 domains: abuse, emotional, physical, and sexual abuse; neglect, emotional and physical neglect; household challenges, exposure to domestic violence, household substance use, household mental illness, parental separation, divorce or death, and incarceration of a household member. The ACE score reflects the number of categories experienced, not the severity, frequency, or duration of those experiences. It is important to recognize that the original ACE framework does not capture all forms of adversity. It does not include factors such as social determinants of health, chronic environmental stress, or medical trauma, all of which can significantly impact child development and long-term health outcomes. Each category equals 1 point. The score is cumulative. The most important finding: as ACE score increases, risk increases. Higher ACE scores are associated with depression, anxiety, substance use, chronic disease, and suicide attempts. This is called a dose-response relationship. The more exposure, the greater impact. ACEs are not just events. They represent repeated activation of the stress response. Over time, this leads to chronic cortisol exposure, inflammation, altered brain development, and impaired regulation. ACEs are experienced by the body, not just remembered by the mind. Children exposed to poverty, housing instability, community violence, and discrimination are more likely to experience higher ACE scores. This reflects increased exposure to stress environments. This is not about individual failure. It is about cumulative risk. An ACE score does not diagnose a condition, predict exact outcomes, capture all forms of adversity. For example, medical trauma, community violence, and racism may not be fully reflected in ACE scoring. This is important. ACEs are a screening tool, not a complete picture. High ACE scores increase risk, but they do not determine outcomes. Protective factors, especially stable relationships, can significantly reduce impact. Neuroplasticity allows for change, and resilience modifies trajectory. When using ACE screening, ensure emotional safety throughout the interaction. Support the child with brief regulation strategies as needed. Avoid re-traumatization by not probing beyond what is necessary. Normalize the conversation and reduce stigma. Provide appropriate resources and follow-up support for child and family. Screening without support can increase distress. Assessment must be paired with intervention. Clinical judgment in ACE's case. A 13-year-old presents with declining grades, irritability, and frequent headaches. ACE score is 4 recognized cues, behavioral changes, somatic symptoms, elevated ACE score, analyze cues, possible chronic stress exposure, prioritize, assess safety and mental health risk, generate solutions, refer to behavioral health, strengthen school and family supports, take action, initiate trauma-informed care, evaluate, monitor symptom improvement. The ACE study changed how we understand health. It showed that childhood experiences shape lifelong outcomes, but it also showed something equally important. Risk accumulates, and so does protection. As nurses, when we identify adversity and strengthen protective factors, we change trajectories.